Can I explain vitality testing and the other question that was asked about the median maxillary suture, just when the participant number goes out to its original, so everybody can benefit from it. You can just wait 1 more minute and then I'll just answer these 2 questions. Okay, I think we had around about 80. Achha, 2 questions there. I thought I'll just answer them before moving forward. Number 1 was about the presence of the maxillary suture. If you cannot see it in a patient, then you can automatically assume that this patient is between 15 to 19 or more than 19 years old. So no, in this patient, I probably think this patient is above that age limit. That's why you cannot appreciate the suture in this patient. Okay. And the second question was regarding vitality testing. Well, vitality testing is basically the domain of the endodontic specialty, but still I will talk a little about it. Vitality testing you can do by 2 means. You have thermal means and you have electric means. I'm sure you must have gotten or seen an electric pulp tester in your undergraduate studies, or at least read about it. So that is one way of determining vitality. And the second one is by using either a heated gutta percha or using maybe carbon dioxide ice. You can use that to determine vitality testing. So these are some of the methods by which you can use, determine the vitality of a tooth. I won't go into the specifics since it's not really my domain, but you can read about them online or any standard endodontic textbook in that regards. All right. Well, this is presentation will probably go at least for this 40-minute limit as well, and maybe even a bit after that. So if you have any problems attending it, I will be uploading its recording. So it's up to you if you want to attend it right now or if you just want to wait for the recording. Okay, thank you, Shakir. Shakir is a very close junior of mine, and thank you for giving that update. You can do thermal testing by these methods and cold testing with these methods as well. So this is how you can determine vitality. Okay, moving on. Now, can you look at these 2? There are 3 arrows in this. two of them are pointing towards the same structure, and one of them is pointing towards a separate line. So can anybody tell me what these two lines are? One arrow is the palate, one is the sinus. Which one is the sinus? Is the double arrow one the sinus, or is the single arrow one the sinus? Two arrows is the sinus. Thank you, Dr. Amara. And what about the single arrow one? Double arrow sinus. All right. It's the palate. Yes, very good, Dr. Jamal. It is basically the nasal floor. So the point where these two lines meet, where your nasal floor meets the floor of the maxillary sinus, or these two lines meet, if you just tilt your x-rays, your screens 90 degrees to the left, you will see that it forms an inverted Y. All right? It forms an inverted Y, and this is called the line of Ennis. Okay? So sometimes people mistake this for a pathology, but this is actually not a pathology. And this is just two normal structures which are meeting on an X-ray. Usually, sometimes your nasal floor can go posteriorly, or sometimes your maxillary sinus can extend that anteriorly. And when these two meet, so this will form the Y line of Ennis. All right? Is that clear? Dr. Verma has raised her hand. Yes, please. If you just tilt your screens 90 degrees to the left, you will see how it makes a Y. All right. This is basically the stalk, the straight portion of the Y, and hang on. This is the Y. This is the straight portion of the Y, and these two form the those arms which are extending towards right and left. Okay, so is that clear now? Okay, excellent, fantastic. Okay, moving on. Okay, that was about maxillary anterior anatomy. Now let's talk about maxillary posterior anatomy. You have few structures over here which are peculiar to this region. The first one is the floor of the maxillary sinus. Second one is your maxillary tuberosity. You can also see the zygomatic process in some cases. You may also see the coronoid process, and you may also be able to see the hamular process. So let's try to see all of these in one X-ray. G, can anybody help answer this question? Just put your answers in the chat box. We'll start off. What do you think these three arrows are signifying? We have a comment here. No, Dr. Nurasha, the nasal floor is not the palate. You can't appreciate the palate as a separate line on periapical X-ray. Okay, this is everybody saying this is the sinus floor. Excellent, Dr. Shakir. Again, this is basically your zygomatic process. Where is the maxillary sinus in this then? If you see this line over here, if you just follow my mouse, this line over here, this is your maxillary sinus, all right? And this structure, which you can see, this portion of it is quite intensely radiopaque. This is your zygomatic process. This is basically the zygomatic buttress, which is coming on top of the maxillary first and second molar, which is a common cause of failure of your local anesthesia. All right. So when you see a dense radiopacity in this region, in the upper 6-7 region, know that this is the zygomatic process that you are looking at. And this line, which I'm redrawing with my mouse, this is your maxillary sinus. All right. So I hope we've cleared that up. This radiopaque crescent-shaped structure which looks like half a moon. This is your zygomatic process, okay? And this line, which is extending, just follow the mouse. This is your maxillary sinus, okay? I hope that's clear. Okay, coming towards, well, this buttress, since it is dense cortical bone, so local anesthesia has a tough time navigating through or diffusing through this cortical bone. So it may or may not be able to reach the apices of the teeth where it can cause local anesthesia. It's exactly due to the thick cortical bone. Like आप इसको इस तरह समझ सकते हो that why is when we give infiltration to the lower 6, 7, 8, why is that ineffective? Why do we have to give a block anesthesia? It is because that thick cortical bone does not allow the diffusion of local anesthesia through that thick cortex so that it can reach the apices of the tooth where the nerve is basically entering the tooth. So this zygomatic process causes that phenomena here in the upper arch. Okay? Hope that's clear. Okay. What about this long arrow over here? What do you think this structure is? Yes, excellent. This is your maxillary tuberosity. In this patient, it is quite prominent because this patient has removed his upper third molar. So that's why you can see it quite big. What about this broken arrow over here? What do you think this is? Styloid process does not emerge from the maxilla. Hamular notch. Yes, this is basically your pterygoid process. Okay, very nice. So I'll show you the hamular notch in an upcoming slide. Okay, what about the star-shaped structure? What do you think this is over here? Excellent. This is your coronoid process. When you tell the patient to open wide, in those cases, the coronoid will come forward and downward. So it is possible that if you extend your periapical X-ray quite posteriorly, so you may be able to capture this area of the coronoid process on the X-ray. So this is again not a pathology. This is something normal that you might see on an X-ray if you're taking an X-ray of this region. Okay, so excellent, very nice. Let's move forward. Okay, the part where you are seeing multiple small arrows, this is basically your hamular process. And the hamular process is important for two reasons. Number one, it provides attachment. This is the superior origin of your pterygomandibular raphe, number one. And number two is that if it is grossly enlarged, it may cause a condition called hamular bursitis, which may be a cause of poorly defined pain in this region. When the patient is swallowing, he may say, I have pain in the palate of this area. So you'll have to examine the hamulus in this region intraorally. If you feel that it is markedly pronounced and when you palpate it, the patient is having the same amount sort of pain. So this hamulus may need reduction through surgical means. Okay, Dr. Aisha has asked a very good question that can we comment on the relation of root apices to the sinus from this X-ray? No, you cannot. Because the sinus and root relation is basically three-dimensional in nature and this X-ray is basically two-dimensional. So again, thank you so much, Shakir. The best tool to comment on the relation of the root apices to the sinus would be a CBCT. However, you can have one or two, I would say, maybe indicators, not something which is a surefire, but indicators that maybe this root is out of the sinus, is that when you look at the apices in that area. You may not, just check if you can see any PDL space around that apice. Like, let's look at this X-ray over here. This is the root apice, which seems to be lying inside the sinus, but you can see a faint black line all around the apice of this tooth, and this seems to be surrounded by bone. Okay, so if it was completely inside the sinus, there would be no PDL space in it. Okay, so this is an indirect indicator that you may or may not, that if you are going to extract this tooth, and if you do it atraumatically, so inshallah you will not create a communication into the sinus. Where is the zygomatic process in this particular radiograph? You cannot see it in every X-ray. Not in every X-ray will the zygomatic process have come so inferiorly that it will be on top of the maxillary 6 or 7 tooth. Hamular process, enlarged hamular process, it's the condition it produces, if it is causing pain, that is called hamular bursitis. B-U-R-S-I-T-I-S. Yes, thank you, Dr. Maya. So that can cause pain if it is enlarged. So in that case, usually some sort of surgical intervention is needed, and that needs to be done. I'll show it to you in the coming picture. This is the area, the circled area which you see. This is the area of your hamulus. All right. You can maybe even appreciate that this is your pterygomandibular raphe. This is the superior origin of it. You can see it over here. This line, this line. This is your pterygomandibular raphe. All right. So if you palpate this area with your fingers and it is tender on touching and it appears excessively prominent, so it can be one of the reasons of diffuse non-localized pain in the palate. Sometimes patients may present to you that way. Okay. All right. I hope maxillary posterior anatomy is clear, so I can go ahead. If I can go ahead, just put it in the chat box. Okay, fantastic. All right. Now let's come to the mandibular anterior anatomy. Now in the mandible, you again have some structures which are specific to the mandible, and if you see them on an X-ray, you can they will help you in recognizing that this is indeed a mandibular X-ray and not a maxillary X-ray. The first of them is the genial tubercle. You have a mental ridge. You may also see the presence of nutrient canals, and there can also be a lingual foramen. So let's come to it. Okay, let's start with these 4 arrows over here. What do you think this structure is? This sort of a triangle shaped radiopaque line that is crossing from the one side of the premolars to the other side of the premolars. I'll upload the recorded meeting on all of the WhatsApp groups from where you got this invite. So don't worry about that. Yes, this is your mental ridge, basically. Okay. So if you see a radiopaque line in the anterior mandible, and you can appreciate that this is not a periapical X-ray, this is a mandibular occlusal X-ray. All right. You can see the occlusal surfaces of the molars, premolars, and the anterior teeth over here. This is not a picture that you will see in a mandibular periapical X-ray of the anterior region. This is a mandibular occlusal X-ray. So this is basically your mental ridge. No, this is not a mental canal. I'll show you the mental canal in another slide. A mental ridge is basically that portion where the mandible is divided from its alveolar process to the mental protuberance. If everybody just puts if you can just put your hands on your chin, and from your chin, if you start to go upwards, you will appreciate that it is sort of like a diagonal line which then suddenly goes upwards. So the portion where this line suddenly goes upwards, this area is basically your mental ridge. What is a mental ridge? Mental ridge is just a demarcating line where it sort of divides your mandible from the alveolar bone and the mental protuberance. That is basically a mental ridge. Is it clear to everybody? If there is any confusion, please feel free to ask. Okay, excellent. All right. What about this long arrow over here? What do you think this is pointing towards? No, this is not the genial tubercle, but since you've identified it, I'll highlight it anywhere here. The small arrows over here, these are pointing towards the genial tubercle. Can you see this small triangle shape? If you just follow the mouse, the small triangle shaped protuberance on the lingual side of the mandible. This is your genial tubercle. It provides attachment to your genial muscles. What about this? Excellent. This is your lingual foramen. So if you see, you may not be able to appreciate it very much, but if you maximize the brightness on your screens, you will see that this is sort of like a radiopaque circle in which in the middle there is a very small radiolucent area over here. So this is where a branch of the lingual artery goes inside the mandible to provide it with nourishment. Okay? So this is the entry point for a branch of the lingual artery to enter the mandible. That is basically the function of the lingual foramen. So you may, if you are unaware, you may classify it as a pathology that there is some sort of a growth, a cyst or a tumor that is growing over here, and you discovered it in the very initial stages. But when you open this area, you will find absolutely nothing except an artery which will bleed a lot. So this is basically the lingual foramen. Okay. Achha. Now coming towards the mandibular posterior anatomy, you will see the following structures. One is your external oblique ridge. Second is your internal oblique ridge, your mandibular canal or ID canal. You will also see the mental foramen, and you will see the nutrient canals in addition to the mandibular fossa. So let's try to identify these structures on the upcoming X-rays. G. What do you think this topmost arrow is pointing towards? Excellent, Dr. Ufak. This is basically your external oblique ridge. Okay. Your external oblique ridge is basically the continuation of your ascending border of ramus, and it crosses the mandible in this way that it will seem like there is a dense radiopaque area crossing your 8 and your 7. So this hole, just if you can follow the mouse on the screen, starting from here all the way here, this is your external oblique ridge. All right. This is as you can see, it is a very radiopaque, very white line. So this is your external oblique ridge. All right. Okay. So what about this structure then? What do you think this is? This radiopaque line which is crossing over here. Excellent. This is your internal oblique ridge. All right. Now some people will ask, then where is the ID canal? So I'll show you the ID canal in upcoming picture. Maybe it's not very clear in this one. Okay. Okay. Lastly, what about this third arrow over here? What do you think this is? And this is pointing towards this entire radiolucent sort of area over here. What do you think this is? Excellent. This is not your mandibular foramen. This is not your mandibular canal. It is not that wide. Yes, it is your mandibular fossa. basically. All right. This mandibular fossa is formed beneath your internal oblique ridge, and the more prominent it is, the more radiolucent it will appear on your mandibular periapical X-rays. All right. This area basically houses your submandibular gland. Okay. So your mandibular fossa, this basically houses your submandibular gland, and it starts directly beneath your internal oblique ridge. Okay. Sure. Okay. Now we are continuing with the posterior anatomy. Now can somebody tell me what this small arrow is? Yes, this is your mandibular canal, or this is your inferior dental canal. So if you just follow the arrows on the screen, you can follow this one line over here and the superior line following here. All right, so this is your mandibular canal. All right, okay. So this basically carries your ID nerve. As you can see, it is quite far away from your first molar, but it usually gets closer and closer to the teeth in the region of the third molar. Especially when you are doing an impaction, you have to make sure that this nerve is not close to the tooth or is not involved with the tooth. Otherwise, it can cause temporary or permanent lip anesthesia or paresthesia. So, acha, coming to this broken arrow, what do you think this structure is? Excellent. This is your mental foramen. Okay? This is a continuation of your mandibular canal. In this portion, this foramen, what it does is the ID canal divides into two parts. The first part is your incisive nerve, and the second is your mental nerve. So what the incisive nerve does is it enters the foramen. It keeps on going inside the foramen, inside this area where it is no longer appreciable on X-rays, and it gives the nerve supply to your mandibular first and second premolar, as well as your central lateral incisors, as well as your canines. Okay, that's what basically the incisive nerve does. The mental nerve, it basically exits this foramen and it goes on to supply your lip and other soft tissue in this area. All right, so that is the function of your mental foramen. Usually it is present between these two teeth at a level below the apices of the mandibular first and second premolar. So where I'm drawing an imaginary circle with the mouse, just focus on that. Here you will usually find the mental foramen, but sometimes it can be present at the apex of fourth, or the second most common site after between these two teeth is at the apex of your mandibular second premolar. So this is where you can find the mental foramen. All right. Now, what do you think this is? This black arrow over here. Okay, a very excellent suggestion. Mental nerve loop. It's not a mental nerve loop, but I'll discuss the mental loop here as well. Yes, this is your nutrient canal basically. Okay, the nutrient canal, this is the closest image you will see of the ID neurovascular bundle actually providing arterial or venous blood supply to the tooth. And this is not normally present on a periapical X-ray. You will only see this if the teeth in question are periodontally compromised. Okay, when there will be significant periodontal bone loss, that bone loss will result in loss of mineralization. When that loss of mineralization occurs, it will make those nutrient canals prominent. So in this case, this patient has periodontal problems, which has basically helped to make this nutrient canal prominent. So an excellent suggestion by Dr. Tabassum was given here that it can be the mental nerve loop. The mental nerve loop has different, is basically a continuation of your ID nerve, but it has various patterns of exiting from the mental nerve. It does not just like this is your ID nerve, so it does not just go and exit in a straight line. So the most common way by which it exits the mental foramen is by forming an anterior loop, and that is that before exiting through this foramen, it extends forward, okay, right about till 3 mm, and then it comes back and goes out to the mental foramen. So that is called the anterior loop of the of the mental foramen, and that is a structure we have to be cognizant of while doing implant planning. Okay. So, but there are various other methods by which sometimes it can form a posterior loop or some other loops as well. But the most common way of exiting is the formation of the anterior loop. Okay. You may have seen this in your contemporary oral and maxillofacial surgery. Yes, this is why we place an implant 5 mm anterior to the mental foramen. 3 mm का anterior loop होता है and 2 mm आपने distance देना होता है from the nerve, so 3 plus 2 is equal to 5. Okay, Dr. Zainab is asking, the broken arrow looks like a bone, resorption type apical pathology. How do we differentiate this from the mandibular canal? Again, you will not just go on the X-ray. If you think this is a pathology, again, mental foramen का जो size है वो भी around about 5 millimeter तक होता है. So if you feel there's a इसका diameter 5 millimeter से ज़्यादा बड़ा है, तो you can suspect a pathology. Again, you can also go for vitality testing of the tooth, see if there has been any periodontal type concerns from the patient. So it's not just based on X-ray. आपको अपनी clinical judgment भी यहाँ इस्तेमाल करनी होगी. You can percuss the tooth. If it is tended to percussion, that is maybe one sign कि यहाँ कोई periapical pathology है वो develop हो रही है. And if you want to be 100% certain, so you can obviously go for a CBCT. Okay. Any questions from regarding this? If there are no questions, then I'll move forward. So just let me know. All right, I'll take that as yes. Okay. This meeting is about to finish in 5 minutes, but we're about to start what is probably the most important topic of this presentation, and that is your OPG. So, चलिए मैं थोड़ा सा इसके ऊपर बात कर लेता हूँ, and the rest we'll take when this meeting has to finish. Okay. OPG discuss करने से पहले I just want you to know a couple of things. OPG में जिस तरह आपको mandible नजर आता है, you know that the mandible is not really in that shape. आप OPG पे देखते हो, it feels like it is a completely flat structure, but OPG is not really. OPG के मुताबिक जिस तरह mandible होता है, उस तरह तो असल में mandible नहीं होता ना. Mandible is basically a U-shaped bone or a horseshoe-shaped bone. तो OPG जो है basically आपका 3 X-rays का निचोड़ होता है in a way. ठीक है? And what are those 3 X-rays? It is basically your a lateral X-ray of your right side, of your left side, of your right side, and a PA view. ठीक है? So it is basically in 3 X-rays का निचोड़ होता है. So that's why sometimes when it is said that if a patient cannot stand for an OPG, because for an OPG you have to stand still for about 5 to 10 seconds. मसलन एक बच्चा है, उसका आपने वो करना है, you know, pediatric patients जो आपके होते हैं, they are not very cooperative with X-rays. So an alternate is that you can order either 2 lateral films and one periapic, one PA film, which is this one. This is your PA view of the skull. So one PA view and 2 laterals, one of the right side, one of the left side. These 3 images, these basically combine to form an OPG. So what are the anatomy that you see in OPG? I'm sure most of you know anyway, so let's start anyway. What do you think is number 1? Excellent, fairly straightforward. That is your condyle. What about number 2? Excellent. 2 is your coronoid. G, number 3. आप आंसर्स लिखते रहें, just write with it कि which number do you suspect is what which structure. 3 is your meatus. Fantastic. That is your external acoustic meatus. Very good. G आगे 4. जी, nobody seems to be answering 4. क्या बात है? 4 and 5 are basically 4 जो है आपका mastoid का shadow आप कह सकते हो, 5 जो है ear lobe का shadow है, ठीक है? G 6. 6 is not the coronoid. अभी से मैं बता दूं, वो आप पहले से 2 के साइड पे 2 जब आपने नंबर किया था तो that was that. No, 6 is not your sigmoid notch. Sigmoid notch आपका ये एरिया होता है, ठीक है? Zygomatic buttress is in this area, 6, 7. Tuberosity तो ये एरिया है आपका जहाँ ये 8 पड़ा हुआ है. Yes, ये आपका pterygoid process है, ठीक है? This is what you are seeing. It is superimposed on the coronoid, so it's not very clear. Again, not important. Acha. G, what about 7? What about this structure over here? Excellent. This is your pterygomaxillary fissure. Okay, this is a very important structure for both orthodontists and maxillofacial surgeons because this is the posterior limit where we for orthodontic surgery जब हमने यहाँ leafort one osteotomy करनी होती है तो इस structure की identification is very important in that regard. Number 8 जो है that is your zygomatic arch. ठीक है, probably not very clear again in this one, but हो सकता है this might be the zygomatic arch in this one. G, what about 9? Let's just speed it up a bit if we can. We only have a minute to go. G9, nasal septum, mesial suture. 7 is your pterygomaxillary fissure. ठीक है, PTM उसको कहते हैं. G9 is your anterior nasal spine. Excellent. G, what about number 10? G, yes, 10 is your sinus. ठीक है. What about 11? Okay, we have less than a minute, so I'll just hold it off till now. 11 is your ramus. So we'll stop at ramus. ठीक है, and बस ये meeting दोबारा start होती है तो I will फिर carry on. कोई question हो तो खैर जल्दी से लिख दें. Somebody raised their hand. I'm sorry, मेरा ख्याल नहीं था. There's still a lot of structures left actually. OPG सिर्फ ये नहीं, आगे भी काफी slides हैं on OPG. 3-4 हैं.